thanks to everybody for coming tonight. It's great to have everybody here at the Eastern Food Allergy Conference.
This is the hardest part.
Yeah, here in Palm Beach, Florida. Thank you very much for coming. We have a great night ahead of us, I think. Some great discussions. My name's Dr. Douglas Mack. I'm joining you from Canada, so I do have a little bit of an accent, if you can understand. I know these guys can. I'm thrilled to be here, and I'm really excited to have two of my really good friends who have contributed to food allergy and have really shaped how we manage food allergy in North America and around the world. So this is a real privilege for me. I want to talk to you. We do have the opportunity to ask questions. Please scan the QR code that you can see ahead of you there. Connect to the Wi-Fi network that you see ahead of you. Keep this lively and interactive, and I think a lot of good learning can happen. Once again, you can also view the slides, access today's content, etc., and participate in any polling. So today, guys, what we're going to do is we're going to talk about the food allergy exchange, and we're going to talk about diagnosis, some of the changes in treatment, and how do we navigate some of the transitions that happen when we are dealing with these patients. So once again, I'm your moderator, Douglas Mack from Canada. I've got my good friend Catherine Anagnosti, who's a professor of pediatrics at Texas Children's Hospital and Baylor College of Medicine. Another good friend of mine, Shazad Mustafa. I'm division head from the Rochester Regional Health in Rochester, New York. Not far from where I am as well. And I think we're going to have a great discussion tonight. And I think one of the cool things, and I think, you know, this conference probably wouldn't have happened 20 years ago, would it? Because at that point, what did we do? We kind of when I finished my fellowship, and when you finished your fellowship, it was kind of a diagnose and adios. I'll see you in a year, and here's your epinephrine auto-injector. But I think what's really changed is that over time, we've done a much better job at diagnosing food allergy, but also starting to provide actual treatments for these patients. We can talk about things like oral immunotherapy. We can talk about biologics. We have others in the pipeline which we didn't have before. And I think it's really cool because what we can say to our patients is that their life is going to be very different than what it was when 20 years ago, 25 years ago, when we were seeing patients for the very first time. It also, I think, entails a lot of shared decision-making. And that's what we want to go today. We want to talk about the pros and cons of some of the approaches that we have here today. Because I think one of the key things that I'm learning in this voyage of the evolution of food allergy treatment is that one size doesn't fit all for all patients. So we want to show you today at least a couple of patients and walk through what our decision-making might be as we approach these patients and what some of the challenges might be as well. And with that, I'm going to turn over the first case actually to Catherine. So take it away.
So I'm going to talk about Jacob, who's a 1-year-old child with a peanut allergy. He first developed symptoms when he was 8 months old after tasting a small amount of peanut butter, and within minutes, he developed quite a lot of skin symptoms. He got some erythema on his face, some facial flushing. He got some urticaria around his lips and mouth, some generalized itching, and also some mild lip swelling. And the parents report that he also became quite irritable and fussy, but thankfully there were no issues with his breathing, and all of his symptoms resolved pretty much as soon as he got some oral antihistamines in the emergency department. He also had a second reaction following the first, about 10 months of age, after drinking yogurt that contained cow's milk. Within a few minutes of ingestion, parents report significant vomiting, diffuse urticaria on his trunk and his extremities, and also worsening eczema patches on his cheeks later that day. So pretty much a mixture of IG and non-IG type symptoms. Again, the respiratory system was not affected in any way. There was no wheezing or any respiratory distress, and also there were no cardiovascular sort of symptoms. So he was seen by a local allergist who did some labs, and peanut IG was noted to be 3, and the Rh2 component 0.36. So both of them were what I would call mildly positive. So this kid is interesting because he also has atopic dermatitis in addition to the reactions that the parents were reporting, and this is not uncommon, especially for this age. Atopic dermatitis is a very common comorbidity. Parents reported that this started when he was 3 months of age, and they also report that it has been persistent. He has had these patches on his cheeks, his trunk, and his flexural surfaces for many months now. And they also reported that he had frequent flares of his skin. They had identified some of the triggers, including heat, drooling, and they also reported incidental food contact as one of the triggers. They were using emollients, but they only saw a partial response to this, and when asked about steroid use, they confessed that they did not really like using steroids very frequently, so they were only used intermittently, and they were low potency. Again, very common story. I'm sure that you have all encountered similar patients in your practice. So when we look at the burden of disease for this particular patient, there are quite a lot of components to think about. Obviously, the dietary restrictions are one of the most prominent. He was advised to avoid both milk and any dairy from his diet, as well as peanut. There was a lot of anxiety from the caregivers surrounding his diagnosis and a lot of safety planning. The parents said that he was obviously crawling all over the place around the house, touching everything, putting stuff in his mouth, so that created a lot of concerns for them in terms of potential accidental exposure to his food allergens. They hadn't actually removed the foods from the household, but they were considering it, at least until they could feel that they had good control of this. The other aspect to consider in food allergy, especially someone with more than one food allergy or someone with food allergy like milk, which is an allergen that is in a lot of things, is the impact that it may have on growth and nutrition. And I mentioned milk because milk is a very big part of the diet, especially from the younger children. You have to consider a lot of things, including potential calcium supplementation for a lot of them. And then there are the social and practical limitations that we see in food allergic individuals, inability to participate in a lot of activities from fear of accidental exposure, having to check labeling. Of course, with someone so young, this burden falls onto the parent and the caregiver. And in addition to that, you have to think of the comorbidities, in which, in this case, the eczema, because the eczema comes with a burden of its own, including symptoms like constant itchiness and scratching, but also anxiety and stress about potential connections that people often make between foods and eczema, which we know that in most cases are probably not there, but they still create a significant burden for the caregivers. And you also have to think about therapies, how to treat it, flares, and all these things.
I think this is a common case that we see every day. We've all seen this patient come to our office, and this is a patient that you saw. But I want to actually, move over to Shahzad for just a second. Look, what testing do you think, is there anything else that you would do in this patient? And I'll come back to you in a moment, but what are any other tests that you might consider for this patient?
Yeah, I mean, I think it's going back to basics, but the first thing remains in medicine, getting a good diagnosis before treatment, right? So you want to nail down the diagnosis, and that often goes beyond skin testing and IgE levels. So consideration for a food challenge, and we can talk about pros and cons, but that's something that I always consider. Historically, we've done it for two reasons: to either confirm or refute a diagnosis of food allergy, or to prove natural tolerance over time, right, for allergens that are food allergens that are outgrown. A third consideration now, which we do sometimes, not all the time, and it's not necessary for all the therapies, is actually to establish a threshold dose.
Sure.
That actually matters in how families decide if they want to treat a food allergy with a therapy and which therapy that might be. So that's not something we always do, but it's something we're considering more and more, and we certainly discuss it with our families.
How about you, Catherine?
Yeah, I totally agree. I think for cases like this, especially when the symptoms are limited to the skin, it is definitely worth doing a food challenge, because a lot of times you may find that they kind of fly through without problems, or even if they do get something, it's so mild that then you have to balance it out with what may happen if you take the food out of the diet for a long period of time versus potentially eating small amounts without any problems or symptoms, or even tolerating some symptoms like eczema flare-ups.
Yeah, I mean, those diagnostics weren't terribly high. The history was not terribly concerning for most of these. And it may also even help you to predict whether this kid might actually outgrow their milk allergy if potentially they're even tolerant of a baked product. We can consider, actual milk or peanut exposure in a food challenge, but what about baked products? We can maybe predict whether this kid's going to outgrow it. Catherine?
Yeah, I think we covered this already, but it's really a very much of a key message that when the history is questionable or there has been no convincing history of reaction, you really want to do an oral food challenge, and you want to do it in a timely manner, at least as soon as possible. It remains the gold standard diagnostic tool for food allergy, and we've already covered the reasons for why we would go there. Including establishing a threshold dose, especially if you're considering initiating therapy. Still important to do it in a setting that is prepared to handle significant allergic reactions and anaphylaxis. I think most places nowadays kind of try to classify food challenges as sort of low risk, moderate risk, and high risk. High risk, think of your sort of research food challenges. Those are high risk where we're basically trying to find out how much they can tolerate before a significant reaction happens. Low risk are the ones where we pretty much expect them to fly through because the allergy isn't there, or maybe it has been outgrown, and the moderate is kind of the gray zone in between the two. That's how I think about them. What I would like to say is that for settings that don't feel they can handle the high-risk challenges, I would still encourage people to do at least the low risk or maybe even the moderate risk if possible, because I still think that it's our gold standard tool, but it's very much underutilized.
I agree, and especially as we're now looking at definitive treatment options, it's always easy to treat a patient who's not actually allergic, isn't it? Yeah, right.
Yeah,
Can I add something there? And I appreciate being a clinician in practice and seeing patients 4 days a week, that some settings it's difficult to perform food challenges. And if that's the case for you in your setting, I would encourage you to work with someone who does, because you can work in tandem. I think it's important. And I also like to remind patients, because there's a lot of anxiety that goes with food challenges, every meaningful food allergy study that we quote starts with a positive food challenge in that study.
Question.
So that is really part of the process.
Agreed.
Absolutely. So talking about treatment, I guess the most common question that I get is, what are your considerations? How do you select basically patients for treatment? And these are all things to consider. Obviously, eligibility is something that is either there or isn't. If someone's not eligible, they're just not eligible for that therapy, right? You don't have very much room to sort of work with. But pretty much everything else you can work with. So patient age is important. The type of the food that patients select for therapy is important. Whether you are treating single food allergy and multiple food allergies, this is also important. Then you're looking at sort of patient-related factors like what the baseline quality of life is and what the burden of the disease is. Do they have any comorbidities? And the most important factor is the last one, actually, the patient and the family goals and preferences. Because you may think that somebody would fit a certain therapy in your mind, but actually they may think completely differently. And because they are the ones taking the therapy and they are the ones who will have to adhere to it for most likely lifelong, right? For most therapies that we have available right now, we think they were going to need them lifelong. It is actually their decision. So when, for example, I consult patients on OIT and we do our shared decision-making conversations, these are all things that we touch upon and sort of go through. And it may not be in the exact same detail for every category because people sometimes want to focus on a specific part of this, but we definitely cover benefits and risks. And for OIT, the benefits are basically surrounding the fact that OIT increases your threshold to a targeted food allergen. So you can eat more after successful OIT. And all of the other benefits derive from that. So you have a less severe allergic reactions on exposure, your anxiety diminishes, your quality of life likely improves because you no longer have anxiety. Everything derives from this significant change in, or clinically meaningful change in threshold. And in the same way, the related risks to OIT, again, relate to the fact that you're giving someone the allergen, that's the food they're allergic to, so they can have reactions. So this is the main sort of risk, and these reactions can vary from mild to moderate to severe, including anaphylaxis. And there is also a small risk of EOE that I always mention to patients, although we haven't really managed to identify if there's a true causality here or whether it's just a correlation. You have to talk to them about what the therapy entails, what monitoring, how many visits they have to do, how often they need to come to hospital, any sort of additional adjustment visits that you may have to do because of dosing issues. And then you have to talk to them about lifestyle changes so that they can see if they can fit this in with their lives. They have to do the updoses usually in the clinic. The daily dosing, however, in between updoses is done at home. They may require continued avoidance, and they need to have their epinephrine available at all times. There are some restrictions in terms of when they can exercise, and also some external factors like illnesses can actually affect desensitization and may need dose adjustment until the illness goes away. And those are all parts of the discussion that we have during shared decision making. You want to make this comprehensive, but you don't want to make it too sort of full of detail for every little category, and usually it's not finished in one session because there's so much to cover. Generally, we are considering oral immunotherapy for any age. There are some differences when children are very young, like Jacob. We have found in the studies that were published so far that there is a high degree of desensitization in this population. There's a higher potential for remission. So if you stop therapy and you basically don't give the allergen for large sort of duration of time, they can still tolerate large amounts. And this is quite unique for the small age group. You generally see better long-term outcomes, at least from the limited data that we have available. And there are children who start OIT very, very young and will end up with negative skin tests and ability to eat the food ad lib. And we see this more often in the young population than in the older kids, where it's actually the exception rather than the rule there. There's also a lower risk of adverse events, and generally rates of severe reactions and anaphylaxis are lower in this age group. So these are all things to consider for early OIT, as we call it.
Agreed. And I think that your discussion there, as Catherine was mentioning, that discussion about how to incorporate this and some of the challenges they might face, that does take time. And it takes time to sink in for these families, and it's something that we might discuss a bit more later. But I want to move over to you, Dr. Mustafa. You have an older patient. So you did the younger patient, and we kind of talked a little bit of oral immunotherapy. I want to kind of shift over to the older patient who has a couple of food allergies and kind of decide what to go with them.
Yeah. And before I get to this case, I just want to kind of emphasize something that Catherine said really eloquently, is I personally think, and from that, there's a paper there, the Stacey Jones paper in Lancet. One of the biggest things for OIT with side effects and tolerability and the value proposition of, as Catherine said, higher doses and potentially ad lib consumption is age and your IgE level, your peanut-specific IgE. There's actually a nomogram in that study, if you guys look it up, where you punch in age and IgE level, and it actually spits out a percentage likelihood of resolution of allergy. Yep. Cure is a very dangerous word, I think, but resolution. And I think it's really, really fascinating data, and we certainly use it when we counsel our patients in OIT in the youngest ages.
Entirely.
So moving on to someone who's a little bit older, 11-year-old Emily, has a history of peanut and sesame allergies, so multiple food allergies. First reaction was age 16 months of age, experienced hives with her first known exposure to peanut. It improved with an antihistamine, and at 3 years she had a similar episode of hives and emesis with hummus, and this one was treated with epinephrine. And since age 3, she's now 11, so for the last 8 years, Emily has avoided peanuts and sesame, and she has not had a single accidental ingestion. There's some data that for peanut allergy, about 15% of people will have an accidental ingestion per year. So she's gone 8 years without an accidental ingestion. Tries to maintain social activities, but does feel a little bit anxious, especially when eating outside her comfort zone, which happens for these individuals commonly, restaurants, especially as she's getting older. I think age really matters, and your autonomy with management of your food allergy starts to change as you become more independent. So she's being away from her parents more and more. This, I think, is very important. Her family actually avoids travel. This is something they wish to do, but they avoid to do solely based on the food allergy. And they would like to consider therapies that would make her safer. Not necessarily ingesting the food, but make her safer, especially when away from home in the comfort zone. And Catherine already said this, but I think the single most important point, is the last point on the slide that she presented, is what is the family's goal with the therapy for food allergy?
Totally
and
agree.
depending on their goal is what's probably going to drive your decision.
Totally agree.
Going on, so she has a little bit of what sounds like asthma or exercise-induced bronchoconstriction with some coughing when she plays ice hockey. This improves with the SAPA, albuterol. She's been treated with oral steroids in the past for viral infections that would not resolve. She has some upper airway symptoms, congestion rhinorrhea, so some allergic rhinitis. She uses an antihistamine intermittently, doesn't really use the nasal steroids. It's modestly affecting her quality of life. We have her peanut and sesame allergy, so she's got at least exercise-induced bronchoconstriction, maybe a little bit more with virally induced asthma. She has allergic rhinitis. She carries an epinephrine autoinjector. She actually has multiple devices. She uses albuterol for exercise-induced bronchoconstriction. In an 11-year-old, we could debate if she should be on SMART therapy, but for now she has albuterol and she has cetirizine. So here's Emily's testing. She's sensitized to aeroallergens, trees, and ragweed. Her food allergy testing is fairly reactive for peanut and sesame. Her total IgE is 431. Her peanut is 3.6, and her ARH2 is 2.9, and her sesame is 1.04. So she's clearly sensitized with a pretty good history. But if you're meeting her at age 11 and her last reaction was 8 years ago,
Sure.
there's some room, right? Some room
Agreed.
for discussion. You do spirometry. She is actually obstructed even when she's not symptomatic in the office, and she has a little bit of a bronchodilator response. And her exhaled nitric oxide, if you guys are using that as a validated biomarker for eosinophilic airway inflammation, is meaningfully elevated at 51 parts per billion.
And I'm going to point out that spirometry is quite common. We do spirometry on all of our patients looking at possible food allergy treatments. And we quite commonly pick up on asthma that the parents didn't know was asthma. And they would call it reactive airways disease or whatever else we want to call these things. And it's quite common. And it's very, very relevant for our decisions about how we're going to treat these patients.
Can I ask you, Doug, if you find that, how do you treat their asthma?
Yeah, well, because this is asthma, right? It's a great question, and I think it plays. There's two sides to this. I think the first is that when we're looking at oral immunotherapy or other types of treatments like this, for us they need to be on an inhaled corticosteroid. That we won't start it without that, to be frank with you. But it also might make me decide to pick like an omalizumab. So I'm going to let you continue with this. Yeah.
There's actually a really fun paper. I'm at Rochester Regional Health in upstate New York from the University of Rochester. Sean Fry is the first author, who said if you actually label children with reactive airway disease, they have delayed appropriate management of asthma.
Right, exactly.
And they actually have poorer outcomes while they're labeled with RAD.
Yeah.
So just something to chew on, because we hear that thrown around a lot. Oh, my kid doesn't have asthma, they have reactive airway disease.
We try to drill it into our fellows. Do not say RAD. Yeah.
All right, so we have Emily here. She has allergic rhinitis. She has not reactive airway disease. She has asthma, and she has peanut and sesame allergy. So again, considering, is she eligible? She's eligible for oral immunotherapy, right? She's eligible for omalizumab, which is FDA approved for management of IgE-mediated food allergy in anyone over the age of 1. I think I would really caution clinicians from kind of making judgments of who's the right candidate for which therapy. I really, really think this comes down to a discussion, and patient values often surprise us when we ask. Patient age is important. I think we touched upon the importance of age with oral immunotherapy. There's no such data to support that there's a gradient of age and efficacy and safety when using other therapies like omalizumab. So that's important to consider. The type of food. So what do you do oral immunotherapy for? There has I don't think I did that, sorry. There has historically been an FDA-approved product for peanut oral immunotherapy, which is going away this summer.
Yep.
So I think people are aware of that. So what types of oral immunotherapy do you offer? We do not, in our office, offer immunotherapy for all food allergies. Do you, Catherine?
We do, yeah. We actually offer OIT to any food, pretty much, yeah.
And I know you do.
As well, yeah.
So again, depending on who you're seeing, what city you're seeing them in, what institution you're seeing them, your access to some of these therapies might be different, particularly oral immunotherapy, where the vast majority of allergists in the U.S. still do not offer oral immunotherapy. This is super important. How you collect this data is, the art of medicine, the baseline quality of life. Is this individual's food allergy meaningfully impactful on their quality of life? Maybe it's not.
Right.
Maybe she's totally unbothered, cruising through life, no accidental exposures, doing everything she wants. That's great. But capturing that data is important. In our office, we do try to do quality of life questionnaires for food allergy. There are validated quality of life questionnaires. And this is super important. In an 11-year-old, the impact of the food allergy on the patient, who you're taking care of, it'd be very different, and is likely very different than on the parents. Mm-hmm. And rumor has it men and women are not exactly the same.
Right.
Dad's impact on food allergy might be very different than mom's impact. And we see this dynamic in our office all the time.
All the time.
So really, really keeping in mind who you're treating, impact on quality of life. Comorbidities is very, very important, I think. When you have an FDA-approved molecule like omalizumab that has efficacy for other comorbidities like asthma, I think that's a very, very important consideration. And then what are the goals and preferences? Is their goal protection from accidental ingestion, like Emily? Being more comfortable in restaurants? That's very different than a goal of I want to eat peanut and sesame ad lib.
Agreed. And
getting that up front is very, very important, but it's going to tailor the discussion. You guys have anything to add? Or?
Yeah.
Good. So going on to factors here to consider, again, our therapies are really trying to increase the threshold dose for a food allergen. It's not binary. There's a vast gradient in how much you can increase the threshold dose, and that may help pick your therapies. Omalizumab, for example, for a biologic, is FDA approved for multiple food allergens. So when you're doing OIT, it's obviously driven at a food. You can do multi-food OIT, but what we say sometimes is omalizumab is food agnostic, right? It take care of not only IgE-mediated food allergies, it can impact other IgE-mediated conditions like asthma. What is the risk of a biologic? Well, biologics are injections as of now. There are absolutely individuals with needle phobia. Anaphylaxis is reported with biologics. And what's the off-ramp? Not the risk, but the cost of therapy. How long do you do it? Is it indefinite? I say in our office, it's easier to start a biologic for food allergy than know what to do with it once you start it. And that's really something that we're learning, and we're going to learn a lot of coming up. Monitoring, we typically start doses in the office, but these can generally be done at home. Certainly have follow-up visits. And this is, I think, a great discussion point. How do you know it's working, right? And as of today, the only way you know if it's working is a food challenge while on the biologic. Okay. And we offer that to everybody who starts a biologic for food allergy, omalizumab, after about 6 months of therapy. And just in our experience, our very single-center experience, about 2 out of 3 patients take us up on it. And about a third just don't feel comfortable, and we're kind of tracking that stuff too. I'd love to hear if that's your approach and what you guys are doing.
We offer 2, but we wait for a year.
And are your patients taking you up on it?
It's probably a 50-50 split, I want to say. Mm-hmm.
It's one of the differences, I think, when you compared to taking something on a daily basis that you know you're allergic to, right? And I think that's one of the visuals of oral immunotherapy is that they can see that they're taking something and they know that they're able to do that. But we can still use challenges for both of these and to kind of prove that they are working. And I think that is, I think, one of the keys when we're doing the same.
Yep, great. And then how does this impact lifestyle? We talked about OIT, so obviously omalizumab or biologics for food allergy or injections every 2 to 4 weeks based on your weight and your total IgE. This is important, especially in a pediatric population. As someone's weight increases, you have to change their dose over time. And that is meaningful. This is very intangible until you start talking to a patient. And I would say 1 injection every 4 weeks is a very different proposition than 3 injections every 2 weeks.
True.
And that's the variability of dosing here. So if someone might be like, yeah, I think I'm leaning this way, and then you do their IgE and their weight, and they're going to be 3 injections every 2 weeks.
True.
That's a big ask.
Yeah.
So this kind of granularity, these are the discussions that really decide where we're going to go with some of this stuff. And then as of today, we're using biologics, omalizumab, in the setting of food allergy with continued avoidance of the food allergen. I do think this is a room for that we have a lot to learn.
A lot.
That can certainly change, and there's a lot of stuff being done clinically that may be a little bit different than that.
Agreed. And I think one of we've kind of touched on this as we're talking about whether we get these kids into these treatments. Do they need these treatments? And how do we prove that they're actually working? Yeah. And I think that the strategies are very similar, aren't they? I mean, how do you approach this from a treatment initiation perspective? What do you do? Do you do threshold challenges? Do you do it to make the diagnosis, or just to show that maybe you don't need to do treatment? Like, what do you do?
Yeah, so I think it would be unrealistic to suggest that everyone who's going to go on a food allergy therapy needs a food challenge before starting therapy. If you're comfortable with the diagnosis, and you have enough factors in place, I think it's okay to proceed. But I think it provides very, very meaningful information with individuals who may not be quite at a point of making a decision. For example, what is your goal for Emily with a peanut allergy? You want to increase her threshold dose where she feels comfortable, right? She does not need to be eating a PB&J.
Right.
So say you did a food challenge knowing she's allergic to establish her threshold dose, and it happens to be pretty high. That is hugely informative for the family and may actually steer you away from therapy. Whereas where if she was very, very low, very sensitive, and she has a risk of systemic reaction with a cross contact, that would maybe push you towards therapy.
Agreed.
So that's how we approach it. We offer it, but don't certainly necessitate it. But like I said, for once you're on therapy with a biologic, not OIT, we do offer it to everyone.
No, I mean,
that's important too. What's the goal?
When on OIT, I think we would do the same. How about yourself? Like when you have a patient who comes back to you after a couple of years, what do you do from an OIT perspective?
Yeah, there's tremendous value in the threshold challenges, both pre-therapy initiation, but also post-therapy.
I agree.
But I think that a lot of the patients get into this really comfortable space, especially in OIT after they've been on maintenance for a while, especially those on higher maintenance than the 300 milligrams, which is kind of our standard, that I find that the interest is actually becoming less over time to have a full-blown food challenge. This probably also ties in with the fact that a lot of them don't necessarily enjoy the taste, so they don't see themselves as eating a lot intentionally. And in terms of accidental exposures, they are still quite sensitive to the smell of the food and the taste, so it is highly unlikely that they will accidentally ingest a huge amount.
And that's especially, we published that in the older age group, that they have a significant taste aversion, especially if you're over the age of 6, and you've seen this yourself, that they don't want to eat all they can of the peanuts, whereas maybe a 2-year-old might want to do this. Yeah. And there is a big difference between those two groups.
Yeah, actually for the young ones, the uptake is higher, and often they are the ones that will end up with ad lib ingestion, right? And the parents really like this, and they see the value in it, and they are very much for food challenges.
The other thing that makes it different is the type of food.
Right.
My experience is most peanut allergic individuals don't have an interest in eating it. They're averse to the smell and taste.
Yeah.
That's very different than milk or egg or wheat, where there's a real interest in incorporating into the diet.
Yes, I agree.
So there's so much nuance here, and that's why I don't think it's very easy to pick out the perfect patient or the candidate.
No, I mean, and I want to just push this discussion further a little bit more. And I think when we talked a bit about the shared decision making for both of these. Now, this is focused primarily on oral immunotherapy. We did a Delphi panel kind of talking about what do we need to talk about with families before they start oral immunotherapy. And this is talking about the variable patient response, unpredictable level of desensitization, partial or full desensitization, SU, remission, etc. But I think this was important. It's the dreaded D word. What happens when you discontinue? What happens when you discontinue any of these therapies, okay? And that isn't just OIT. When you stop one of these therapies, these patients do lose their clinical effect, okay? And why does that happen? Believe it or not, it's primarily social factors. It isn't medical. It isn't reactions to oral immunotherapy that drives the discontinuation of this. We don't have that data on what drives discontinuation of omalizumab, to my knowledge. But for OIT, this is what we published, looking at the social factors, the burden, the exercise restriction, et cetera, anxiety as well. So these are some of the reasons why we would discontinue. And I want to kind of think about, when do I look at maybe switching or combining, or what do I do? Like, what do you guys do in this scenario? Like, how do you approach this?
Yeah, this is a really interesting question, and I think it will become more and more complex as new therapies come into the landscape and receive approval. So the first thing that I say to them is that there is no first-line therapy as such, right? Because a lot of times they come in and it's like, well, what's the first line? The first line is the one that fits the patient's goals and preferences. And I always make a point of saying to them that even if you make a decision now for therapy A, it doesn't mean you commit to it for life. If you find that for whatever reason therapy A doesn't work for you, whether you're having side effects or it's not bringing the outcomes that you were expecting to achieve, or your circumstances change over time, children grow, they may have different preferences, you can switch over. Now, the data we have for switching over is extremely limited to almost none. Right?
Agreed.
So when you actually get into the weeds of switching therapies, you realize that there is almost nothing out there to guide you. So it has to be a little bit of a experimentation and a little bit of hit and miss. But what I say to patients is, if you're on OIT and it doesn't work for you, there's still, omalizumab to consider. And there is also, going back to avoidance, of course, that's the other option.
Always reasonable.
Yep. Same for omalizumab. If it doesn't work for you, there is the option of OIT, or there is, again, the option of avoidance. So in a way, you're bringing back the initial conversation that you had, but on a different level.
Shazad.
I just want to stress what you just said. I mean, we obviously have a big food allergy cohort in our practice and do a lot of food allergy therapies. The vast majority of our patients, north of 80%, choose avoidance.
Right.
And that is perfectly appropriate.
Agreed.
There's nothing wrong with that, and it works for them.
Agreed.
So I just think that's an important point, because
Agreed.
it's fun to have therapies, and there's a lot of these therapies that are very, very well suited for some of our families. But the vast majority, as of today, still continue to choose avoidance, and it's the right decision for them.
I want to take a second now, and there are some great questions before we get to some of your key takeaways, and some of these have really come up based on the discussion that we've been having, actually, and I love to talk about the doses of a food challenge, or conceptualize for me, when you do a food challenge for a patient who is on any therapy, whether it's omalizumab or oral immunotherapy, what doses do you pick? Because it's going to vary. All three of us are going to do different. What do you do for your doses for to either oral immunotherapy or omalizumab in the middle of treatment? What do you do?
Yeah, so again, you have to work with your patients. So the first thing that I do is I ask them what they're interested in. Are they interested in eating large amounts of the food, or are they interested in just knowing whether they're protected from accidental exposure? And that is going to guide me towards the dose that I'm going to use. So for example, I do a lot of early OIT now, so I have a lot of infants in my program, and the parents will often say, we want them to free eat, right? So I will go super high with the challenge, right? And I will get them all the way to full dose to see if they tolerate it. And then I have others, like a teenager who doesn't necessarily like the taste of peanut, and they just want to feel protected, in which case I don't need to do that, and I can go with a low, sort of moderate dose challenge.
I feel better about my answer now, because Catherine said the same thing. I think it's really important to ask their goal, and if they want to just prove protection from accidental exposures, you can do a very low dose challenge. You can do a single dose challenge.
Sure.
For peanut, we often do 600 milligrams, which is about 2 peanuts.
Yeah.
But yeah, if they have an interest in introducing it into their diet, then we go to a full serving as well.
I think it's important as well that if a patient can tolerate 300 milligrams of peanut protein, the probability of an accidental reaction is well under 1%, well under 0.05%. This is extremely low probabilities. If they can tolerate 1,000, they're basically, by Joe Baumert's modeling, considered non-reactive. So we don't have to go to these 5,000 milligrams unless the families want us to. If it's about cross-contamination and make sure they don't have those reactions accidentally, we don't have to go nearly as high as we often think. And sometimes the treatment dose is sufficient to prove that. What are the foods that you like to treat, that you commonly treat, and the ones that you don't like to treat? This is a great question that someone asked.
Yeah, this is a great question. So I treat all foods.
Yeah.
I have to be honest that in my earlier years, I shied away from milk because I find it one of the hardest to treat. But over time, with more individualized protocols and approaches, I actually found that you can desensitize the majority of patients to milk as well. So I don't really shy away from any foods. I think this comes with sort of experience in treating a lot of patients, and also experimenting a little bit and not necessarily sticking to a specific protocol. But you can actually tailor your protocols, your OIT protocols, to different patients and achieve the desired outcome. The caveats are, you may have to put up with some significant reactions that are unexpected. You have to consider what the family is actually willing to accept when you do this, and time. Time is a very important factor. So you may actually need much longer periods of time for those that are difficult to desensitize. For the majority, you will get there. There will still be a small minority that you want.
How about you?
I agree with OIT there. The food that we've had the most difficult experience with omalizumab, since I was covering the Emily case, which kind of bears out with the very limited data from the OUtMATCH study, is cashew and pistachio seems to behave pretty differently in our office. And some of the reactions that we've had on therapy they've been predominantly to cashew and pistachio. The N is small. I think there's a very important caveat there. We're offering these food challenges on biologic therapy, omalizumab, after about 6 months. And if you look at the supplemental data in OUtMATCH, which is where all the good stuff is buried, by the way, you got to get in there. Even individuals with cashew get desensitized, but it takes meaningfully longer. Yeah. So as always, Catherine's probably smarter than I am that she's waiting a little longer to offer these challenges. For cashew, we tend to be a little bit slower on offering the challenges. But we've had a couple of reactions there. But that's the other thing. Even for such a well-studied, highly efficacious, well-tolerated therapy like omalizumab, there are non-responders. And that's very disappointing. And from a scientific standpoint, those are the folks that are actually more interesting to me than the people who are responding. Like,
why are they doing this?
It doesn't make sense.
Totally agree.
Yeah.
I agree with you, Catherine. I think that when we started doing OIT, we actually started with milk, and it was almost enough to scare me off because it was harder. I found moving to peanut was a-okay, and then moving into the tree nuts very, very similarly. These days we do a lot of tree nut, but we'll often do single nut like cashews or which will cover pistachio, walnuts that might cover pecans, etc. So we do a lot of that. Legumes are challenging because we don't quite know, which one to target. Wheat, I have trouble with as well. I don't love this one as much. It seems to cause me difficulty anyways. I want to go back for just even, are there times, and this is a great question that someone sent in very early on, at times when you wouldn't consider a food challenge? What are the reasons why you would not consider a food challenge? I'll start with you, Catherine.
Yeah, so one of my first questions when somebody asks me for a food challenge is whether they are willing to reintroduce the food in the diet. If they're not, it's probably waste of time, right? This is mostly for the kids who are looking into sort of outgrowth of their previously diagnosed food allergy. In terms of therapy, the context is a little bit different. So I guess if somebody has had a very severe reaction requiring sort of ICU admission, because they were exposed to the food, I would probably tell them not to do a food challenge to that particular food, especially if the reaction was at a low amount, because then, it's not that the data is that strong to guide us, but there is that element of sort of previous history that you at least have to give a little bit of credit for, right? And then I guess the other sort of situation where I wouldn't push someone to do a food challenge is if they absolutely do not want to. It's not something you can make people do, right? They have to understand the value of it. And I guess it very much depends on how we present it as well, right? Because if I go to someone and I say, hey, I'm going to do like a really tricky test on you, I'm going to give you the food you're allergic to, and you may have anaphylaxis, that's not the right context for the food challenge, right? You have to say, this is our gold standard tool, we're doing it for this particular reason. There is a chance of this reaction happening. There's a chance of a severe reaction. You have to place it in the right context. Otherwise, you're guiding the patient with your own bias without even realizing it.
Agree. Shazad?
Totally agree. A very, very severe life-threatening reaction where you have a good history and the dose was relatively small leading to that. I would pause.
I'm going to add the uncontrolled asthmatic. And I think asthma to me, it's a contraindication to OIT. It's a contraindication to uncontrolled, I should say. Uncontrolled, untreated for me is a no starter for oral challenges. So it's something that I think we need to really put a lot more emphasis on, to be frank with you. We have about a minute left. I want to hear your key takeaways in 20 seconds. Shazad, what are your final messages here today?
It's an incredibly exciting time to be practicing food allergy. I think we should be considering food allergy therapies for all patients who are eligible, and then having those nuanced discussions. It's incredibly rewarding and some of the most fun stuff I've done in my 17-year career.
I would say work with your patient to find out what they're really looking for. Don't make assumptions. Don't make any judgments, which I'm sure most of us actually don't do anymore, right? but also make sure that you give them the right information within the right frame, because sometimes the way that we phrase things can actually influence them in their choice.
I think communication in this scenario is huge. We're going to have lots more treatment options coming in the next couple of years. Our job is going to become far more challenging because we're going to have a lot of options, I think, coming in the near future, and we have already that are here. And I think that's great for our patients. They have options to treat, and this is something that is extremely exciting. That's why we're here today. And I really want to thank our presenters, and I really want to thank the Eastern Food Allergy and Comorbidities Conference. It's been a great conference so far, and this has been a great discussion. I really want to thank those who joined us live and those at home. Thanks for your questions, and we look forward to seeing you next year. Thank you very much.